All right. Great. Well, hello everyone. Hello to everyone online and welcome to those of you in the studio. My name is Cyan Bryan. I'm the Health Equity Lead at Stanford Center for Biodesign. For those of you joining online, you may notice that our branding is new. We're now known as Stanford Center for Biodesign and not Biocenter for Biodesign. And I just want to give you a warm welcome to the Health Equity. These are talks that happen monthly on various topics around health equity and innovation. And the purpose is that we acknowledge innovation from every person in equity, but if we're thoughtful about who we innovate for, the types of innovations we produce, how we ensure that they actually reach the people that need them most, use innovation as a powerful force for good and for decreasing inequity. And so today's topic is going to be explained in a short while, but we're just thrilled that you can join us for this really important dialogue. For those of you who's your first time joining today, we do have a YouTube channel with all previous talks, and this talk will be recorded. So the run of events is that we're going to have an hour session today. I'm going to welcome Dean Michelle Barry in a moment, who's going to introduce our speaker and tell you a little bit more about the Center for Global Health Innovation here at Stanford. We're then Sarah Hooper's going to be here for 30 minutes, and we're going to have some time for Q&A afterwards, because the point of these talks is also really that it's a conversation and not just a lecture. And so with that, I'd really like to give a warm welcome to Professor Michelle Barry, who is the Drs. Ben and A. Jess Shenson Professor of Medicine and Tropical Diseases at Stanford University. She is the Director of the Center for Innovation and Global Health and the Senior Associate Dean for Global Health. A leading voice for advancing women's leadership in medicine and global health, Dr. Barry is the founder of the Gates-funded international nonprofit Women Lift Health. She's also an elected member of the National Academy of Medicine, the Council on Foreign Relations, and the American Academy of Arts and Sciences, Chair Emerita of the Board of Directors of the Consortium of Universities for Global Health, and the past president of the American Society for Tropical Medicine and Hygiene. She's most recently written The Exclusion of Women Climate Scientists from COP Meetings and Leadership Roles, that is also published in the area of climate's impact on megacities, tropical diseases, human and planetary health, as well as global and refugee health. So we're really happy to have you here today. And before we give her a round of applause, I just want to say, global health is not foreign health. This is why we think it's so important that the Center for Global Health Innovation is here today, because we want to acknowledge that inequity everywhere is important to address, including locally. And so could we please give a big round of applause to welcome Dean Michelle Barry.
That was more than generous. Yeah, thank you very much. Good afternoon. As you've heard who I am, I have the pleasure of not only introducing our guests here at Stanford, but also I was asked to say a few words about the Center for Innovation and Global Health. And yes, global is local, and we can spend a few seconds on that. Basically, the center is an interdisciplinary center that is based at the School of Medicine, but really involves all of the 8 schools at Stanford. While our challenges, many challenges around global health, we also look at the local issues. There are 3 major pillars that we think about. And when I got here to Stanford, I spent many, many decades at Yale, too many. And when I got here, I realized I had to look around to see what the niches were that we could be value added. And we are not a big event, like some of our neighbors up north. But what we are, we're really a very special multidisciplinary university. The areas that I thought we could make a difference in is human and planetary health, climate health. The second area is something that I'm very passionate about, and that is the lack of women leadership in global health and in healthcare in general. The third area is refugees and vulnerable populations. So that's what our center is really focused on, and that's where we work. The special programs that I think might be of interest to you are our seed grants. And our seed grants are between $25,000 and $50,000. Give out about $700,000 a year for you to actually do projects. As long as you are really collaborating with a PI, that is a faculty member. I don't care whether you're a NGO or anyone from another university. you come up with a project that is going to have impact in global health, and we'll try to fund you. So our Sea Grant program, I think, is one of our signature programs. The other program I'll just spend a few seconds talking about is our new program, SASH, which is a Stanford African Scholars Program, where we're actually bringing 25 faculty, mid to senior faculty African fellows to Stanford to spend a period of time where they'll learn a new skill, teach us their skills, and then go back with a $50,000 grant to actually implement what they learn at Stanford and what they have shared with. So those are the kind of, it's just a drop in the bucket of the programs around, but I thought it was maybe of interest. And apropos of this session, local is global. We really are very interested in some of the structural issues that you have, the structural determinants of health inequity, because that's really not just local, really around the world. So, now I get to introduce you. Okay. So I am pleased to introduce today's speaker, Sarah Cooper, JT, who will guide us through this topic. She's professor of practice at UC Law, San Francisco, and associate dean of the UCSF-UC Law SF Master of Science program in Health Policy and Law. She also serves as executive director of the UCSF-UC Law Consortium on Law, Science, and Health Policy. Sarah graduated with a BA in Law and Society from UC Santa Barbara. She earned her JD from the University of California, Hastings College of Law. Professor Cooper has dedicated her career to developing innovative medical legal collaborations that can advance equity in healthcare. She focuses on health justice, aging, and complex care, and has been involved in clinical, really fascinating. I hope we can talk about some of these clinical interventions, such as the Medical Legal Partnership for Seniors Clinic and research project with the Dementia Care Ecosystem Clinical Trial. She has a special interest in complex care, and particularly in the role that law and lawyers can play in actually helping underserved individuals in our. So welcome to Stanford. Yep.
Wonderful to be here. Thank you to Cyan, my dear friend and fellow for many years now. So as you heard, I am a law professor and I think about health law and policy. So I'll give away the ending. The key structural determinants that I'm going to be talking about are mostly law and policy. And so I want to really explore, how many of you are familiar with U.S. healthcare policy? A couple. Okay, we've got some U.S. healthcare policy. Anyone with legal training or background? Oh, this will be fun. Okay.
You can tell us anything.
Well, perfect. Okay, so I promise not to do Socratic method. I'll spare you that. So I'm going to try to do a lot in this talk. We'll see how far we get, and I definitely want to encourage this as a conversation. So feel free to interrupt me if you have a question. But I actually want to start. I think that the best way into these issues is to really start with a story. And the story comes from our work in the Medical Legal Partnership, kind of writing alongside healthcare teams, particularly in hospital settings, and seeing social diagnosing, health inequity sort of bubbling up in our healthcare systems. Okay, so I want to introduce you to Mr. S, who was a 72-year-old man who lived alone in Oakland. He was a veteran who lived on about $24,000 a year. His neighbor checked on him periodically and was concerned about how he was doing on his own, so he had someone checking on him. And one day, Mr. S called his neighbor and asked if it was safe to eat cat food. And this was the neighbor's kind of last straw. He was like, we have to do something about this. And the thing that he thought of to do was to pack Mr. S into the car and drive him to a hospital on the other side of the bay and see if the hospital staff could do something. So the hospital staff evaluated him and determined that he had undiagnosed dementia and he had COPD and some other chronic conditions that had been poorly managed.
And they determined that while he did need help, it wasn't hospital level care that he needed, and he really didn't need to be there. And he needed to be discharged. However, because of his dementia and his kind of frailty and his conditions, and his social isolation, the team didn't feel it was safe to discharge him back home. So they looked into long-term care options and encountered many barriers to those. And Mr. S hadn't named any legal surrogates to navigate these things for him. And so the healthcare team decided that a conservator would be able to help him. Any Britney Spears fans here? Okay. So if you're not a Britney Spears fan, conservatorship is the mechanism that we have in the US to take someone's right to make decisions for themselves and give that right to somebody else to make those decisions for them. It's a decision-making intervention. Okay. So the healthcare team thought that's the thing that will help us. So the process of figuring out his discharge plan took months. And the conservatorship process was going to take 6 months to a year, probably. And throughout this process, Mr. S was growing increasingly depressed, living in the hospital, and he said it felt like prison. But he couldn't articulate a plan for how to go home, and really the team just didn't feel comfortable letting him go. And I am sorry to tell you that Mr. S lived for 6 months in the hospital, and then he died in the hospital and didn't get to go home. So just to be super clear about this case and what happened here, in one of the wealthiest countries in the world, a Black man who served his country, this case upsets me years after talking about it, spent his last months of his life, and probably a shortened life because of it, in a hospital where the team couldn't figure out how to get him care in the community. And the primary intervention that was being explored was one that would take his rights away to make decisions for himself and transfer this to somebody else. So I just want to make sure we're all on the same page about why this case is so upsetting. Excuse me, anyway, I wish I could tell you that this was an outlier case, but in fact, we have people like Mr. S sitting in hospitals all around the Bay Area, all around the state, and all around this country. And more broadly, it's sort of wild to think about older adults in this position because older adults in the US enjoy more health access than the rest of the population, right? So older adults in the US have near universal healthcare coverage. But in spite of that, older Americans are sicker, as this article from a couple of years ago shared with us, are sicker, more economically vulnerable than our global counterparts. How can that be? How can that be? We have world-class care. We spend more per capita than any other country, right? And we get middling outcomes, sometimes worse than other countries, right? So when I'm talking about health inequity in the US, I think about it with an intersectional lens, right? It's affecting older, disabled, disproportionately women, disproportionately people of color, and disproportionately people with disabilities. Okay. Sorry, this is a really bummer story. So
It's not an outlier. I can tell you, Stanford Hospital has many of those on the board.
that is correct. That is correct. Yes, that is correct. And what's important about that too is that related to the spending part, so we have a category for patients like Mr. S. We call them complex care patients, right? For this term. It also incorporates people with SUD. It incorporates people with kind of multiple complex conditions, including social risk factors that tend to be very high cost for the healthcare system and with fairly poor outcomes, right? So we're spending a lot of money on these people. The complex care population is estimated to be about 5% of patients, but over half of healthcare spending in the US. I don't want to give you the impression that utilization is why we have high costs. We have high healthcare prices, but that's a talk for another day. But one of the reasons that we have a lot of high cost in the US is spending on these populations, right? Okay, so let's drill down more into this. What are some key structural drivers of inequity and of the situation that we're seeing here? going to talk about four, and I promise I am going to talk about how geography plays into all of this. So the first one, healthcare cost and fragmentation. Because we have multiple payers for healthcare in the United States, right? We're not a single payer system. There are multiple sources of payment. And so a low-income veteran like Mr. S has potentially three payers of his healthcare, none of whom really talk to each other that well. None of whom are coordinating his care effectively. Talk about what we're trying and it's not really helping. And none of whom fully cover the needs that he has, right? But Mr. S is responsible for navigating those systems and figuring out how to marshal these disparate payers in order to get the care that he needs, right? And I used to talk about that as just like, a specific challenge for people with cognitive disabilities or other disabilities or frailty. But honestly, who's trying to navigate the US healthcare system? It's hard for people with high literacy, right? It's real hard, right? Okay, so this is not a system that helps people access care, even if you have higher levels of literacy and access. But he also, another challenge that we have is that those payers are not equitably situated, right? So depending on your source of payment, you may have a disfavored form of payment, right? In our healthcare system. For understandable reasons, providers feel that it's not covering costs of care, right? So one of his payers is the Medicaid program, which in the US pays for low-income people and pays for all of our long-term care. It is the number one source of payment outside of private pay for long-term care in the US. But it is a disfavored form of payment. So even if you can get a facility to say that they will accept a Medicaid patient, so it's called Medi-Cal in California, it is a disfavored form of payment. And so it is harder to get patients with certain payment coverage to access care for that reason, okay? So fragmentation is a problem in itself. You have to navigate all of that, but then all of those payers are not equitably situated in the US. So right there, you can see where people like Mr. S and truly all of us struggle to get care particularly at the end of life. Okay, so healthcare costs and fragmentation. Disinvestment in the social safety net. So we are an outlier in terms of how much we pay for healthcare in the US. We pay more than most other similarly situated nations, but we are also an outlier in our social care spending in that we spend disproportionately less of our GDP on social care services. And we know that of all the population health contributors, healthcare is a relatively small proportion of what we think counts for population health, right? With social and economic factors and behaviors shaping a much greater piece of that. And so if you think about how the US has decided, and it is a choice, has decided to invest our public dollars, you can see where we have decided to invest it, right? And again, think about a 6-month stay at a hospital, right? $2,000, $2,500 a day per hospital bed times 6 months, about $360,000. And his income for the year was 24, right? So if you think about what we spent on that hospitalization versus what he actually needed in the community, the gap should be pretty clear, right? Okay, so decisions about where we're spending our money. And then economic inequality writ large, right? So, so you can certainly pay for world-class care in the US, right? You can afford it if you can access it. But growing economic inequality has really set the stage for acute vulnerability as we age, right? And so we do have some social structures for older adults in the US. We have Social Security, but around the 1970s, 1980s, we saw a big shift in the way that people prepared for retirement. How many people have a 401k? How many people have a pension? I'm in the UC system, so I'm like one of the last ones, right? Okay, so a pension is a defined benefit, right? You know what you're getting out of it and your employer pays it and you may contribute to part of that, but you know what you're getting at the end of the day, right? It provides some stability. Defined contribution is a 401k plan, right? So you contribute to a market-based tool. We hope that the market holds and bears what we think it's going to bear and that you will benefit from that, right? But think about Mr. S and people who disproportionately don't have access to jobs that even offer a 401k, much less a pension anymore. And you think about he's relying almost entirely on social security for his income. So paying for better care is just not an option. It's just not. And it's going to be not an option for a growing number of our older adults. And then just poverty writ large. So about 1 in 4 Black, Hispanic, and American Indian and Alaska Native older adults lived in poverty last year. One in 4. And then, of course, we have to name a fourth really critical factor, which is that, you know, race and socioeconomic status are certainly linked. But even after we control for socioeconomic status, we know that there are still racial disparities in healthcare and health outcomes in the United States that are the product of structural racism and other forms of social marginalization. So those are kind of the key 4. And to kind of ground us specifically in the Mr. S case, how that might be showing up, we know that older Black and Hispanic Americans, because of lifetime risk factors, right, are more likely to acquire Alzheimer's and other dementias, but are less likely to receive a diagnosis at all, much less one early on, and more likely to report discrimination in accessing care, right? So why didn't Mr. S get support earlier on in the trajectory of his ADRD, right? That's something, it's a train we can see coming. Why didn't we detect it, right, earlier? For me, you know, I think about older adults, I work with older adults, but it's really important to remember that he didn't get here when he turned 65, right? The risk factors, the reasons that we got here have been accumulating over his lifetime, right? It's lifetime advantage or disadvantage. And I should be clear, we often talk about social determinants of health in terms of marginalized populations, but social determinants of health shape all of our health, right? It can be a positive factor, it can be a mediating factor, or it can be a negative risk factor. And it's just sort of like an accumulation of risks and stressors over your lifespan, right? But when you think about, you know, I talked a little bit about access to jobs that gets you set up for a particular kind of retirement. What determines what kind of job you get? It's your social networks, it's your educational access, and then your educational access and your networks depend on the conditions that your parents had, right? That you were born into. So you can see, and then certain health events can be acute episodes that either benefit or really negatively kind of draw down on all of these. So it's a dynamic, I love this chart from Nancy Abbott. I think this is really helpful. So we didn't get here just in the last 6 months. We didn't get here in the last year. We didn't get here when he turned 65, right? He's a Black man that has lived in the United States, right? So there have been some things that he has seen in his life. Okay, so I want to drill down in particular to why geography is such a potent driver of health. And I want to just ask, like, why do you think that is? After all the things we've been talking about, why is it that we would see that lifespan morbidity is closely correlated with where you live? Yeah.
There's like different things. Like I know there's like case in New Orleans where after Katrina, people were planning to put a giant trash disposal unit right in your Vietnamese American community. So sometimes it's deliberate. Let's put the trash here. And there's super fun sites, but then also certain states may choose different laws that.
Yeah, I love that you're immediately calling out law as a driver of that. But where we live, like, do we have trees? Is it a healthy environment or is it a Superfund site? Do we have, access to healthy food? Do we have, just sheer climate and environment is a huge contributor to health. What else? Yeah.
Oh, sorry. I heard someone. I didn't want to.
income and is tied to a lot of other things, how well schools are funded, example, and what kinds of grocery stores are in the area, because that depends on what people can afford. Public transportation, for example, is all connected to income much more tightly than other countries.
Yep.
And that is a huge driver as well.
Yeah.
Where you live, and then of course the houses you can afford.
Beautiful, yeah. Tax policy ends up dictating, like, you know, your schools and it's one driver, right? But a whole host of drivers. Did you have
But access to water.
access to water? Yeah, huge, right? So huge and increasingly challenging with climate change, right? It's a risk factor now, and it's only going to continue to put pressure on certain communities.
History of redlining.
Yeah, haha, yes, thank you. You're way ahead of me. So there's sort of natural environmental variation and resources, right? But the way we distribute those resources is something that we affect as humans. And then who gets to live there is something we definitely affect. And so just real quickly, so you can see a little bit of the data, there's a ton of data kind of showing this association place and health, but just a couple data points for you. So here's a map that shows, you know, California, and it shows life expectancy at birth, and the red is life expectancy it's too small even for me, 55 to 75, right? In kind of inland Central Valley area. And then obviously like higher as you get to urban areas on the coast, right? But then even within our little bubbles, you know, we see variation in the health burden for people depending on where they live. So who knows what the blue area is? It's the Bayview. Does anyone know what the Bayview is? Yeah. It's a super fun site.
It's pretty violent too, by the way.
Yeah. It's a super fun site, and it's also a disproportionately Black and brown community, disproportionately lower income. I think they just were able to open like a food pantry out there, a free food grocery store like this year. It was actually a huge deal. The mayor helped open it, but also a food desert. So when we
Where major public housing is too, so the city's
Yeah.
public housing in Bayview and did not put good transportation in as well.
yes.
So there's a lot going on.
Will you repeat that so those online can hear?
Oh, yes, thank you. So there's a lot of, so there's public housing out in the Bayview, and when they put it out there, they also didn't have a plan for good public transportation at the time, right? So all of these things are really critical. And then something that's also really important to socioeconomic status is we often get our jobs through our networks, right? And so if you are segregated or you happen to live in communities where you don't know a doctor, you don't know an engineer, you don't know, or people haven't had access to certain types of careers, it will be much harder for you to see and feel like you have access to those careers or to have the connections or the mentorship to get into those professions, right? So you think about like how we get opportunity, and a lot of it is through social network, right? So thank you for calling out redlining. That was my next slide. And just to reinforce, you know, I'm a lawyer, so I can be negative by kind of bent, but I promise I'll give you some positives in here too. It can serve as a positive force, but a lot of the health disparities that we see are often the product of negative effects of law and policy, right? So redlining is an excellent example of that. For any of you who isn't familiar with redlining in the United States, it was a practice by which we segregated, sorry, I say we a lot too, because I feel like we need to take collective responsibility for these things. We collectively as a society decided that it would be a good idea to segregate people by race, right? And so we used property law to do that. So restrictive covenants that basically affected the way that people could sell or inherit or distribute their property with the explicit intention of keeping Black people out of certain neighborhoods, right? So the map, yeah.
I see Martin Luther King there signing, so I'm curious what the it's perceived to have some other
So that's-
beneficial.
That's gonna be my positive effect.
Oh.
Great
Sorry.
question. No, great question. Yeah, sorry, this is a little misleading. So on the left on the right is the problem, right?
Okay.
It's an example of law serving to create geographic difference and reinforce differences and to segregate people by neighborhood, right? Which then has compounding health consequences over people's lifetimes. On the left, an example of the fact that we can change that law, right? We no longer, at least in law, although sometimes often in practice, we no longer permit explicit segregation, although we still have some de facto segregation, right, that we're trying to remove. But on the left, right, is Lyndon B. Johnson signing the Civil Rights Act of 1964, which sought to protect against discrimination in employment, voting, and housing. Right. So this is just to underscore that these disparities, these inequities are not inevitable, right? They're not genetic inevitabilities, they're not biological inevitabilities. And law is also a product of the choices, right? So I just want to drive that home. This is to drive home the point that I think someone made already, which is that we don't get to decide where we live, right? And the US has an ugly history of state sanctioned and well, we can talk about current day too, state sanctioned genocide, violence, and oppression, right? And so to connect this to geography, right? This was under the Jackson administration in 1830. The Indian Removal Act was signed, which authorized the president to basically displace and forcibly move Cherokee people out of their native land into another part of the country. And do you think they got the best land? No, right? And so we are just beginning, I think, to really contend with the legacy of harm, not just dignitary harm, right, but of health harm, that decision, that action in 1830 still, how that still plays out in our country today, right? Even for the survivors of that. So this is another, I think, just to sort of underscore some of the data we have around the effects of redlining and some of these state sanctioned actions that we take. I think this was a UCSF student actually that looked at associations between redlining and age-adjusted rates of emergency department visits and due to asthma, right? And so you can see the associations between different neighborhoods and increased ED use. Okay. So related to healthcare, I think the other thing to kind of keep in mind, particularly when we think about Mr. S, is that the legacy of segregation and discrimination is in his lifetime, or certainly within his early years, right? He's born into this and he has lived this his whole life. So the Hill-Burton Act of 1946 did some good stuff. It developed a lot of hospitals, but it permitted explicitly segregation of those hospitals, right? And so if you think about when hospitals that are still around may have been first funded and built, they were built into a segregated regime, right? It wasn't until 1962 that the Supreme Court at the time actually said, we have to desegregate our hospital systems, right? It's a requirement of the Equal Protection Clause of the 14th Amendment to the US Constitution, and began the process of actually attempting to do that, right? Because during the time of segregation, there was this idea that, well, it's okay, we'll just have separate facilities. Stop me if this is like too much. I'm not sure who's familiar with this history. The kind of theory was they're all separate but equal. We'll just have, hospital facilities for Black doctors and Black patients, and we'll have other facilities for white doctors and white patients. And as long as they're the same, it's fine. It's fine to segregate people in that way. And of course, they weren't the same. Of course, they weren't given the same resources, the same supports, in addition to just the basic dignitary impact of that, right? That you're not allowed to share the same facilities. So that was the theory for a long time, endorsed by our Supreme Court at the time, that said that separate but equal was an appropriate concept to have, not just in hospitals, but in schools and in other, drinking fountains, all areas of American life. And then in 1962, earlier than that, we had started to unwind that, but in hospitals, it wasn't until 1962. 1962, right? Right? The past is not past. The past is not past. The Civil Rights Act of 1964 addresses social conditions, right? So all programs that are federally funded, including healthcare coverage for people in federal programs. And so, in these programs, we can't discriminate on the basis of race, color, or national origin. But there have been some fights over the years about how we actually enforce these rules. And that is kind of an ongoing battle, and something that we've seen since the Obama administration is that under the Affordable Care Act, so the health reform law that the Obama administration passed, there was an attempt to broaden civil rights laws in healthcare settings. We had some change in administration, and the subsequent administration then attempted to narrow those provisions. And then the current administration has now issued a final rule to rebroaden. So elections matter in the United States. And it just is sort of like wild that within the space of 10 years, you can have radical swings in what we think kind of basic human rights and access to care should look like. How are we doing? Okay. Oh, I realize we're at 1:53. I have a lot more to tell you about structural reasons that we have inequity in the US, but I want to just pause and see what questions or comments you have at this point. And I'm happy to keep going, but
Sarah, I will also say we have about 40 people online. And
Yeah.
so if the people online want to ask questions, they're welcome to. We do have someone monitoring the chat, so we have the person.
I can just keep going. Or I totally bummed you out. It was one of the two, or maybe both. Okay.
There's a question online asking about the 14th.
Amendment?
I'm assuming.
It's a good one. What's
The
the
question is, can I ask a question? Can I talk? Hold on, Richard. Let me quickly allow you to speak. Richard, you should be able to unmute now.
Awesome. Okay, can y'all hear me?
Yeah.
Can you guys hear me? Okay. So thank you for this lovely talk. Sorry, I should have typed it, but I couldn't put the words together very quickly. So basically, the question is: you alluded to the 14th Amendment. The reason why I want to bring it up. So okay, just top of mind, there are possibly 3 different domains of intervention, and just very quickly, for the time being, disaggregate intervention, prevention. So intervention. 3 possible domains: legislative, let's call it civil society, i.e. culture, and then the judiciary. You already mentioned the problem with legislative, right? Right-wing person comes in, boom, all the protections are gone. Well, not all, but you know what I'm saying. Culture is a different kind of thing. However, the judiciary, at least with the 14th Amendment, it seems to me that that can provide some measure of staying power. And I wonder, and I'm saying this because I don't know if you know this case, Katie A. v. Bonta. It was filed in a central division of the federal district court in California. And basically, it was brought on behalf of all kiddos who were either in foster care or who were at risk of being placed foster care, because the state basically did not uphold the 14th Amendment with respect to Medicaid. Unfortunately, that case settled, so it's not part of the record. But the question to you is, when thinking about the gentleman that you began the story with, what kinds of legal mechanisms exist on the books right now, such that people can begin to bring cases under the 14th Amendment, such that this sort of thing stops happening? And I realize that this will probably go into the domain of whether or not the 14th Amendment is regarded as a positive obligation that the state must provide, or merely a negative protection. Now, as we know, there are different interpretations on this score with respect to the 14th Amendment. Would you please, if you have any remarks on this, Is there a path forward there? I'm thinking a multi-decade strategy to begin to file cases in which a positive guarantee of rights can begin to be realized under the auspices of the 14th Amendment? And that's my question.
Great, yeah, great question. Okay, so let's think about Mr. S. And the answer is yes, we already have that litigation. It's so for people like Mr. S, there was a case in the 90s called Olmstead. Has anyone heard of Olmstead rebalancing? Yes, yes. So it's similar to this. It was with people with mental health conditions who kept I not to get too long. So basically the claim was we don't want to be forced into institutions, particularly if our physicians say that we could live in the community with supports. And if a state were to deny funding for community supports and only insist on paying for institutional care, then that is a violation of our rights under the ADA, actually. And the Supreme Court agreed with that. And so it was a suit against Georgia. And so for the last several decades now, we've been engaged in a project to try to get states to invest more in community-based supports and services rather than institutional care settings. And so that is actually a great example of where we sometimes need more litigation, but we actually have the law on the books. It's an implementation and enforcement problem. And one of the challenges with it, and I'll show this to you. So, and bringing us back to place and why place matters, right? So one of the challenges with our system of federalism, so our system of federalism in the US says that there's some things that we can do at the federal level, but a lot of things that states need to do. And that can be helpful because you can advance things. Like in California, we can be advancing strategies that other states don't want to follow us around. It can be a bad thing, right, if you live in one of the states that's kind of stubborn and refusing to implement new strategies. So this is a chart that's showing and that tracks along the lines with Olmstead as well. It tends to be similar states. Whether your state has expanded Medicaid to undocumented immigrants, to include more community-based care, is entirely up to your state legislature and governor, right? And so place matters, right? So one of the reasons we see these disparities is because there tends to be a subset of states, generally in the Midwest and in the South, who are dragging their feet in some of these rebalancing measures. So I'd be curious to know more about the details of the foster care case. And there can be lots of different mechanisms by which we change law or enforce law, but actually not everything requires litigation. And with this Supreme Court, I don't know that I would necessarily always think that litigation is the highest and best strategy, at least for things that could overrule the court. So I don't know if that answers your question, but there is, I would take a look at the Olmstead case. And depending on the facts of your foster kid situation, that may or may not be relevant law. Yeah.
I know someone who works for the Department of Justice, and all she does all day is try to enforce the Olmstead
Oh,
Act.
yes,
So,
yes.
You could share her contact with
Yes. Yes, thank you. Yes, so enforcement is a big problem. So related to my work at MLP, one thing that I've seen in health systems is there's a lot of low-hanging fruit, right? So like those healthcare teams that were working with Mr. S are not necessarily trained in social diagnosing, do not necessarily know the scheme of default surrogates or alternatives to conservatorship. And Medicaid law can be really arcane. It's like, and it can change a lot depending on what the most recent budget appropriation was. So, you know, and social workers are fantastic, but have a ton of patience, right? So we come in, our team as legal aid lawyers, to provide some of that expertise and training to healthcare providers. And I feel like you guys need some good news. So I'll give you some good news. So some of the interventions that we're trying is just supporting and building capacity in health systems to think about equity and to address it effectively, right? And we didn't come up with this idea, although I wish we had. The good news is that there is a broader effort in the US to think about health and social care integration and alignment on a number of levels. So data is one part of it. So tying quality metrics to equity outcomes, requiring hospitals to start screening for and addressing social needs and engage in implicit bias training, like those kinds of things. But then also to think about directly integrating interventions, right? The program that I run, Medical Legal Partnership, is one of those. We directly integrate legal aid lawyers into healthcare settings to advocate for people like Mr. S, not against his healthcare team, but with his healthcare team, right? Like, how do we get in housing? How do we get assisted living to actually take his Medicaid? Yeah.
So some of the inequities that you described, is it more about, would you say, I'm sure it depends, that there's a specific statute or law that enforces that, or is it just kind of being aware of, so talk about navigating and participation, to be able to participate? So I look in Texas, like what my parents went through hospice programs there, and they were great, and they were paid for the whole thing, and they provided great care associated. So, but I just don't think we knew about it because we were inquisitive. Focused on that.
So the frustrating thing about healthcare advocacy is the fragmentation, right? So depending on the source of coverage your parents were relying on, the hospice benefit tends to be quite good across payers. But like long-term care coverage, assisted living, it depends entirely where you live. Right. So California, for instance, has opted into assisted living expansion. And so we have in some counties, but not all, place matters, right? In some counties, but not all, Medicaid will pay for assisted living. So the advocacy strategy depends on the payer and the population. And so is it a litigation problem? Is it an implementation problem? It really depends, which I know is a super annoying answer, but it's the fragmentation is the problem. Yeah.
And so there's also, huge impact on health related to the built environment.
Yeah.
I wonder whether you wanted to speak about like all the laws and policies related to, like sidewalks and tree coverage and parks and things like that.
Yeah. So I love that example. So the question was about, just built environment. And we know that built environment can have a tremendous impact on health. And we know that marginalized communities don't have great built environments or tend to not have great built environments. And what's cool about that is that's actually it's often a local policy issue, right? So when I talk about policy, people always think we have to go to Congress and pass a federal law, or we have to go to the Supreme Court. But there's a ton of power potentially in your local government to affect your local community. And they can sometimes do things at the local level that may be hard to garner traction for. So like Berkeley has done some incredible experiments around public health, around sugar sweetened beverages, around built environments, around the gas stoves, people are not super happy about, but they can kind of innovate in the policy space. And sometimes those are then scaled to other jurisdictions, and there's always jurisdictions that resist them. But think about the power that your local government has through things like zoning and housing enforcement and those kinds of decisions that can make a tremendous impact.
I can tell you, as I attend on the boards, that your patient, Mr. S, is treated like a pariah on the boards. The residents don't round on him. They basically call him a social patient. And he really gets put to the side. And it's really until psychiatry comes in, which is awful because they're diving in, not knowing him, calling him incompetent. And then you get your conservatory. Because they're all working to get him out of the hospital.
Yes.
And not necessarily into a place that's going to benefit him. So how do you break that cycle?
I love that question. Thank you. So this is a lot of the work that we're doing right now. So we've worked with inpatient teams and geriatricians actually, and We are doing a huge training and capacity building push. And one of the things that we found is that people are prematurely saying that someone lacks capacity and they actually don't, or we're applying too high of a standard. Who here could tell me in a quippy 1-minute answer how you would navigate Medicaid to pay for your long-term care? Go. You can't do it, right? Why do we expect Mr. S to do that? Right? It's too high. No one has capacity to do that. We do. We're lawyers. We love this nerdy stuff, but he can't, right? Most people can't. It's an unreasonable expectation. So part of what we're doing is going in and saying, applying a system. So like checklists, like have you actually systematically looked at why you think he lacks capacity? Let's unpack that. Does he actually could he still name someone? Could he have named his neighbor? How do we not know about Meals on Wheels? Part of the reason this case is so upsetting to me is that
He could go back to its cat, get home health.
yes, he could. Yes, and that's part of so the fragmentation. There's disconnection within the healthcare system, but then there's the disconnection with social services, right? They're very underfunded, but we do have them, and they are intended for people exactly like Mr. S. But the people who most need them, like Mr. S, are often the least likely to access them, right? So people like Mr. S are the least likely to access legal aid, even though we have free legal service, not enough, but we do have free legal services, right? So some of these are like not brain science, right? We just need to figure out how to better navigate these systems, ideally better reorient them. So one of the things that we're doing for for people with multiple payment sources like Mr. S in California is to reform and try to streamline and get them into one managed care plan that would coordinate all of these benefits. And so he's not having to navigate at least 2 of those 3. He would still have to navigate 2, but at least two would be talking to each other. So there are some structural reforms. Our Medicaid program in California for the first time is going to start paying for certain housing benefits and advocacy as a medical benefit. Food programs, SUD programs, right? And they're just starting to roll that out. So we're trying, there are things that we're trying to do. And I want to give you hope that there are models, there are good models out there, there are interventions, there are things that we can do. But the big structural stuff, right, requires that you vote and that you pay attention. And I'll stop there.
I have a question online.
Yeah.
Michelle asked when you were talking about the 14th Amendment and Obamacare, what do you think the implication of section 1115 will have on social determinants of health? And she has a follow-up question to that. What do you think the challenges would be with operationalizing it?
With 1115 waivers or with the discrimination, the section sorry, I just want to make sure I'm answering the right question.
Michelle, if you're online, if you see this, I just allowed you to speak. Do you want to elaborate?
Yeah, yep. It's the section 1115 waiver that like CalAIM is under, and states have different names for their version, but it's the waivers for non kind of healthcare interventions, but more social services within Medicaid.
Yeah, so the program I was just telling you about, that's what she's talking about, the permission for states to use Medicaid dollars to pay for social care interventions. So there are so many barriers. One of them is that the main goal of the program is to see if we can save money by addressing these things. So there's a business case underlying all of this, which means that there's going to be a ceiling and there's already a ceiling, right? And many of us feel like to be eligible for these benefits, you are already so far down the risk profile that we're not intervening soon enough. And then it's still going to be a little too late. But I say that also by saying no one 10 years ago would have thought that Medicaid would actually be paying for housing. So we also have to Baby steps, right? Baby steps. A thing that I'm concerned about is I don't think that there are enough advocates who work with older adults or legal aid folks involved in that conversation, who are trained in social diagnosing and know how to do it. I think that there needs to be more people helping to shape what the interventions look like, who actually are going to be performing those interventions or who have a long history of doing them. And this is a constant, in any innovation, in any intervention, a key tenet is ask the people close to the problem, right? And I think they've made some good strides to doing that, but I think we're not quite there yet, and we have more to go. They have done some good things. They've had some like patient advisory boards, gotten some people involved to frame the benefits of the interventions, but they're we have more work to do. And then again, the kind of high level why place matters. So only a few states are using their Section 1115 authority to do this, right? So like Texas is not one of them. So there's states where if you live in that state, and these tend to be states with like high maternal mortality and lack of access to care, and so they have deep social need and would really benefit, but they're not opting into this. So again, like where you live makes a huge difference to me to see this gap widen between states. Yeah.
I think we're not taking any more questions. Professor Hooper, I'm Krista Donaldson. We have a gift on behalf of Biodesign Community. Thank you.
Thank you so much.
One last thing I want to say is I thought you brought up many themes that we hold very dear at Biodesign. One is needs driven, talking to people who are directly affected by the policy decisions, and also the beauty of multidisciplinary. I think you're the first lawyer we've had come speak as part of our health equity brown bag, and that's something we really value multidisciplinary approach here. And thank you so much also to Dean Michelle for also coming and telling us about innovation. So with that, I think we're going to hand over to Sion, who's going to bring us home.
Yes, let me put that there so people online can see. So thank you, Sarah. And then I just wanted to thank everyone, the Centre for Innovation and Global Health, for attending and helping us with these events as part of this time for Global Health Club. If anyone here or online wants to learn more about them, there'll be some folks in the room afterwards, but their websites are also there where you can get in touch with them and learn more. And we're hoping to build partnerships because we recognize doing work in inequity is difficult. We need different people who think differently, bring different skill sets, and to learn together as we go. And that's why we have this series. And I just want to also thank Anja and Deja and the Biodesign team for helping us put the events together. And a last reminder that our next brown bag will be happening in October with Krista Donaldson, our Director of Innovations Impact. She's the former CEO of Equalize Health, and she really focused on creating accessible and affordable phototherapy devices for a variety of regions to make sure that no baby didn't have access to life-saving therapy. And she's going to be talking to us a little bit about equitable design, how we can actually use innovation as a force for equity, and her own lessons, because so often we only share the things that went well, but she's going to share some of the things that were hard and difficult, as well as the things that went well. So we hope you'll join us next time. Thank you to everyone joining online, and thank you again to Sarah, and we hope to see you next month.